Good morning and welcome everyone. This is Grace Lee, Chair of the Advisory Committee on Immunization Practices, and today is Friday, September 22nd, and I am pleased to call today's ACIP meeting to order. I'm going to hand it over to Dr. Melinda Wharton, who will begin with our purpose and our process this morning.
Good morning. Good morning and welcome to the September 22nd, 2023 virtual ACIP meeting. Could we have the next slide, please? Copies of the slides being presented at today's meeting either are already on the website or will be there soon. And a few notes on meeting logistics for those of you who are listening in on the Zoom line. Please keep your line muted until you're called on for discussion. When Dr. Lee opens the meeting for discussion, please use the raise hand function in Zoom to virtually raise your hand. During the discussion, Dr. Lee will take questions first from voting ACIP members, and then, as time allows, from ex officio and liaison representatives. Please keep your video off until we get to the vote. We'll ask ACIP members to turn their video on for the vote. Next slide, please. The Advisory Committee on Immunization Practices is, at its heart, a public body, and engagement with the public and transparency in our processes are vital to the committee's work. For this meeting, we will be holding one oral public comment period today at approximately 2:30 Eastern Daylight Time. To create a fair and more efficient process for requesting to make an oral comment, we ask those interested to submit a request online in advance of the meeting. We give priority to those advance requests, and if there are more requests than can be accommodated in the allotted time, we select speakers through a blinded lottery. Speakers selected by the lottery for this meeting have already been notified, and we thank those who requested an opportunity to make a public comment. Members of the public can submit written public comments on issues coming to ACIP via regulations.gov. The docket number for today's meeting is ID CDC 2023-0076. Information on the written public comment process, including information on how to make a comment, can be found on the ACIP meeting website. Next slide, please. As noted in the ACIP Policies and Procedures Manual, members of the ACIP agree to forgo participation in certain activities related to vaccines during their tenure on the committee. CDC has issued limited conflict of interest waivers for certain other interests that potentially enhance a member's expertise while serving on the committee. Members who conduct vaccine clinical trials or serve on data safety monitoring boards may present to the committee on matters related to those vaccines, but are prohibited in participating in committee votes on issues related to those vaccines. The member may participate in discussions of other vaccines from that same company, but should abstain on votes related to that company's vaccines. At the beginning of each meeting, ACIP members state any conflict of interest. Dr. Lee, that concludes my opening comments.
Thank you, Dr. Wharton. We will move on to roll call. For our ACIP members, I'll ask that you state your name, affiliation, and whether you have any conflicts of interest. We'll start with Ms. Bata.
Good morning, Lynn Bata, Minnesota Department of Health. I serve as the immunization clinical consultant there, and I have no conflicts.
Thank you. Dr. Bell?
Beth Bell, clinical professor, Department of Global Health, University of Washington. No conflicts.
Thank you. Dr. Chen?
Wilbur Chen, professor of medicine at the University of Maryland School of Medicine's Center for Vaccine Development and Global Health. I have no conflicts.
Thank you. Dr. Long?
Good morning, Sarah Long. I'm a pediatric infectious disease consultant and professor of pediatrics at Drexel University College of Medicine. I have no conflict.
Thank you. Just to finish the sentence, she has no conflicts. Dr. Brooks?
Oliver Brooks, Chief Medical Officer, Watts Healthcare Corporations in South Los Angeles, and I have no conflicts. Good morning.
Good morning, and thank you. We'll move to Dr. Paling.
Good morning, it's Kathy Paling. I am professor of pediatrics and epidemiology and prevention at Wake Forest School of Medicine, Atrium Health, Wake Forest Baptist. I have no conflict. Thank you.
Thank you, Dr. Paling. Dr. Sanchez.
Good morning, Pablo Sanchez. I'm Professor of Pediatrics at The Ohio State University College of Medicine. I'm a neonatologist and pediatric infectious disease specialist at Nationwide Children's and OSU, and I have no conflict. Thank you.
Thank you, Dr. Sanchez. Dr. Talbot.
Good morning. I'm Kip Talbot, Professor of Medicine and Health Policy and an adult infectious disease doctor, and I have no conflicts.
Thank you. Dr. Lair.
Good morning. I'm Dr. Jamie Lair in private practice in Ithaca, New York, family medicine, and I have no conflicts.
Thank you. Ms. McNally.
Good morning, Veronica McNally, president of the Franny Strong Foundation based in Michigan, and I have no conflicts.
Thank you. And this is Grace Lee. I'm professor of pediatrics at Stanford University School of Medicine, chief quality officer at Stanford Medicine Children's Health, and I have no conflicts. Let me just do a quick check. We have a couple of members who are dialing in from other places, and they will be joining later, but I will call on them as they join. But for our committee today, we do have quorum, so we're able to proceed. And I just want to take a moment to once again express my gratitude to our ACIP members for taking time from your daily work to be able to join us today. I am hoping this is the last urgent meeting before we move back into our usual cadence. For our ex officio and liaison members, I will announce the organization name, and then please indicate if you're here by stating your first and your last name. We'll start with our ex officio representatives at the Centers for Disease Control and Prevention.
Good morning. This is Dimitri Daskalakis from the Centers for Disease Control and Prevention. Thank you.
Thank you. Center for Medicare and Medicaid Services.
Good morning. This is Mary Beth Hance for CMS.
Thank you. Food and Drug Administration.
Hi, this is Meghna Alimchandani from CBER FDA.
Thank you and welcome. Health Resources and Services Administration.
Good morning. This is Commander Reed Grimes with HRSA.
Thank you. Indian Health Service.
Good morning. This is Matthew Clark from Indian Health Service.
Thank you. National Institute of Health.
Good morning. John Michael from the National Institutes of Health.
Thank you. Office of Infectious Disease and HIV/AIDS Policy.
Good morning. Valerie Marshall, present.
Thank you. We will move on to our liaison representatives. We'll start with the American Academy of Family Physicians.
Good morning. Pamela Rockwell, AAFP, present.
Morning. Thank you. American Academy of Pediatrics.
Good morning. Sean O'Leary, present.
Thank you. American Pediatrics Red Book.
David Kimberlin, present.
Thank you. American Academy of Physician Associates.
Good morning. Marie-Michelle Leger is here.
Thank you. American College Health Association.
Good morning. Sarah Lee, present.
Thank you. American College of Nurse Midwives.
Carol Hayes, present.
Thank you. American College of Obstetricians and Gynecologists.
Linda Eckert, present.
Thank you. American College of Physicians.
Good morning, Dr. Jason Goldsman, American College of Physicians, present.
Thank you. American Geriatric Society.
Ben Schmader for AGS.
Thank you. America's Health Insurance Plans.
Jessica Grubb, present. Good morning.
Morning, and thank you. American Immunization Registry Association.
Good morning, Courtney Londo, ERA, present.
Thank you. American Medical Association.
Dr. Sandra Freihofer, present.
Thank you. American Nurses Association.
Good morning, Chad Riddle, representing the ANA.
Thank you. American Osteopathic Association. Move on to the American Pharmacists Association.
Good morning, Kelly Good, American Pharmacists Association.
Thank you. Association of Immunization Managers. We'll move on to the Association for Prevention, Teaching, and Research.
Richard Zimmerman, present.
Thank you. Association of State and Territorial Health Officials. Biotechnology Innovation Organization. Council of State and Territorial Epidemiologists.
Hello, Paul Cieslak for CSTE.
Thank you. Canadian National Advisory Committee on Immunization.
Morning, Shelley Deeks for NACI.
Morning, and thank you. Infectious Disease Society of America. International Society for Travel Medicine.
Elizabeth Barnett here for ISTM.
Thank you. National Association of County and City Health Officials.
Hello, Matt Zahn, present.
Thank you. National Association of Pediatric Nurse Practitioners.
Good morning, Patsy Stinchfield for NAPNAP.
Morning, and thank you. National Foundation for Infectious Diseases.
Good morning, Marla Dalton for NFID. Thank you.
Thank you. National Medical Association.
Good morning, Pat Whitley Williams. Thank you.
Thank you. Pediatric Infectious Disease Society.
Good morning, Grant Paulson, present.
Thank you. Pharmaceutical Research and Manufacturers of America.
Good morning, Corey Robertson, present.
Morning, and thank you. Society for Adolescent Health and Medicine. And Society for Healthcare Epidemiology of America.
Preeti Mehrotra, present.
Thank you. Are there any members, liaison members who have not been able to identify themselves? If so, would you please raise your hand and I'll call on you? Okay, I don't see any hands raised, so we'll go ahead and move on. We'll move on to our first session for today. Thank you, everyone. So we have Dr. Sarah Long, who will be providing background and opening remarks for today's session on RSV pre-F vaccines. So Dr. Long, the floor is yours.
Thank you. Thank you. Next slide, please. Each year in the United States, children under 5 years of age are afflicted with RSV at extraordinary numbers. There are 100 to 300 deaths and an extraordinary number of cases of morbidity and resource expenditure in the up to 80,000 hospitalizations, 500,000 emergency department visits, and 1,500,000 outpatient visits. Next slide, please. Most children, most infants are infected in the first year of life. Next slide, please. And nearly all by the 2 years of age or the second season of RSV. 2 to 3% of young infants will be hospitalized for RSV. RSV is the most common cause of lower respiratory tract infection in infants, and the highest RSV hospitalization rates occur in the first months of life. 79% of children hospitalized with RSV under 2 years of age had no underlying medical conditions, a very important part for us to remember. Next slide, please. Previously, we have presented to ACIP regarding the RSV epidemiology and burden, the virology and immunology, and the safety and efficacy of RSVpreF vaccine, the cost effectiveness analysis of the vaccine, both in a CDC model and a comparison with the manufacturer model, and the evidence to recommendation framework for RSVpreF vaccine, as well as clinical considerations of the vaccine. Next slide, please. The Food and Drug Administration on August 21st, 2023, approved Pfizer's RSVpreF vaccine for use in pregnant people for the prevention of RSV, lower respiratory tract disease, and severe lower respiratory tract disease in infants born and from birth to 6 months of age. The vaccine is approved as a single dose to be given at 32 to 36 weeks of gestation. In phase 2B and 3 trials, vaccination was given during 24 to 36 weeks gestation. And it was noted a numerical imbalance in preterm births observed in vaccine recipients compared with placebo recipients in 2 clinical studies. Available data are insufficient to establish or exclude a causal relationship between preterm birth and RSVpreF vaccine. Additionally, a numerical imbalance in hypertensive disorders of pregnancy was observed in vaccine recipients compared with placebo recipients. Next slide, please. The FDA approval also included starting dosing at 32 weeks of gestation instead of earlier, and thought that this could reduce the potential risk of the complications from preterm birth until additional safety data are available. This timing would avoid the risk of extremely preterm births where there is substantial morbidity and mortality, and of very preterm births. Similar vaccine efficacy was noted in 32 to 36 week gestation vaccination compared with the overall study population. The FDA considered that the benefit of efficacy of this maternal vaccine outweighed the potential risk of preterm birth and maternal hypertension. And FDA has required the manufacturer to conduct post-marketing studies to assess preterm birth and hypertensive disorders of pregnancy, including preeclampsia. Next slide, please. RSVpreF vaccine is one of 2 available preventive products for RSV in infants. In August of this year, ACIP recommended nirsevimab for RSV prevention in infants. So ACIP recommended nirsevimab in August of this year to be given to infants under 8 months born during or entering their first RSV season, and they are recommended to receive a single dose of nirsevimab, universal single dose of nirsevimab. Children 8 to 19 months who are at increased risk of severe RSV disease and who are entering their second RSV season are recommended to receive 1 dose of nirsevimab. Next slide, please. To be able to understand both of these products, we need to remember that both nirsevimab and maternal RSV vaccine provide passive immunity to the infant. A person develops active immunity from infection or vaccination, triggers an immune response, and immunologic memory provides prolonged protection that for certain infections may be lifelong. On the other hand, passive immunity is the transfer of preformed antibody only produced externally to provide protection to the recipient. It can be provided from the mother to the infant through transplacental route or via breast milk transfer. There is the ability to directly administer some antibodies, such as IVIG or monoclonal antibodies for passive protection. And passive protection provides temporary protection that wanes with time. Next slide, please. So today we have a very large agenda. First, Dr. De Silva will discuss RSVpreF Vaccine Safety Surveillance in pregnancy from the Vaccine Safety Datalink, the plans for the program. Dr. Morrow will discuss maternal RSV vaccine safety monitoring in the VAERS and V-safe systems. Dr. Hutton from the University of Michigan will give an economic analysis of the vaccine. Dr. Ortega Sanchez from the CDC will provide the economic picture of preventing RSV disease. Dr. Fleming Dutra will give the evidence to recommendations framework updates from the last presentation. Next slide, please. And then Dr. Jefferson Jones will give the updated clinical considerations for the use of the unusual use of both nirsevimab and the PreF vaccine. Dr. Peacock then will discuss implementation considerations for maternal RSV vaccine. And Dr. Santoli will discuss vaccines for children resolution. We'll then have a break, public comment, and then we will get to the vote. And should that need arise, Dr. Schilly will discuss adult and pediatric immunization schedule addendum. Next slide, please. Should Pfizer vaccine be recommended? This is the policy question, I'm sorry. Should Pfizer RSVpreF vaccine be recommended for pregnant people to be given during 32 through 36-week gestation to prevent RSV lower respiratory tract infection in infants? Next slide, please. The extraordinary work group members are listed here. Very, very engaged ACIP members, liaisons, ex officio members, expert consultants, and grade consultants. Next slide, please. And you must see here that all of the brain power and expertise of the CDC on vaccines, as well as policy and this vaccine, have been brought to bear. So fasten your seatbelts and maybe find an easy chair. The bulk of the day will now be spent in discussing all of these issues. Thank you, and I turn it back to CDC.
Thank you, Dr. Long. We'll turn it over to Dr. Malini De Silva, who will be presenting on vaccine safety surveillance in pregnancy from the Vaccine Safety Datalink.
Good morning. Can you hear me?
We can. Please go ahead.
Today, I will be talking about plans for RSVpreF Vaccine Safety Surveillance in pregnancy from the Vaccine Safety Datalink. Next slide. The Vaccine Safety Datalink, or VSD, is a collaborative project between CDC's Immunization Safety Office and integrated healthcare organizations in the United States. The VSD monitors the safety of vaccines used in the US through real-world data of rare and serious events following vaccination. The project includes data on approximately 15.5 million individuals across all sites annually, with approximately 115,000 annual live births. Data is organized using a common data model with standardized coding systems. The map on the right shows currently participating VSD healthcare organizations. There are 13 VSD sites that provide clinical, methodological, and data expertise. 11 of the 13 sites provide data for the project. Sites that do not provide data are denoted with an asterisk. Next slide. The VSD's data structure is based on a distributed data model in which each VSD site creates standardized data files used in multi-site studies. Each VSD site defines a cohort for inclusion based on enrollment in the site's health plan and/or care received at the VSD site. Once a cohort has been defined, files for vaccine administrations, medical diagnoses, and procedures from inpatient, outpatient, and emergency department visits, and birth and death files are created. The dynamic pregnancy episode files uses validated algorithms for identifying ongoing and completed pregnancies. This file is updated weekly. Information in this file includes the pregnancy start date or last menstrual period, also known as LMP, gestational age of the pregnancy, and pregnancy outcomes when available. A mom-baby linkage file allows for evaluation of infant outcomes following prenatal vaccinations. Ancillary drug or lab files are available on an ad hoc basis for specific studies, and automated data files are supplemented with chart reviews as needed. Next slide. The VSD has been evaluating the safety of vaccines administered during pregnancy for more than 10 years. This slide shows some of our publications which have evaluated the safety of influenza, Tdap, and COVID-19 administered during pregnancy. Next slide. The RSVpreF vaccine manufactured by Pfizer has been shown to be effective against severe RSV-associated lower respiratory tract infections in infants. RSVpreF clinical trial data on safety in pregnant persons identified injection site pain as the most common reactogenicity event, as well as identifying an imbalance in preterm births in the vaccinated group. Most preterm births were late preterm, meaning they occurred at 34 to less than 37 weeks gestation, and most occurred more than 30 days after receipt of the RSVpreF vaccine. Preterm birth imbalance was most prominent in a single country. Of note, GSK was also working on an RSV prenatal vaccine, but the clinical trial was halted due to an imbalance in preterm birth in the vaccinated population. The etiology for preterm birth associated with RSV prenatal vaccine is unknown. Next slide. This slide lists the goal and some challenges of prenatal RSV vaccine surveillance. The goal is to evaluate the safety of the RSVpreF vaccine administered during pregnancy in the VSD's large real-world population. Challenges of the surveillance work include unknown vaccine uptake, which makes it difficult to provide any power estimates. Additionally, we may see a healthy vaccinee bias where healthier individuals or those with lower risk pregnancies may be the first to be vaccinated. This will be considered in our analyses and when interpreting results. There is uncertainty regarding recommendations for use and administration of this vaccine, which may impact who receives the vaccine. If persons at high risk for preterm delivery are recommended to receive RSVpreF early in the vaccination window, we may identify more preterm births in our vaccinated group. Alternatively, these individuals may be counseled to not receive the vaccine and wait to have their infant receive nirsevimab. The timing of administration during pregnancy overlaps with Tdap recommendations, and vaccine administrations are also likely to overlap with influenza and COVID-19 vaccines. Co-administration of RSVpreF with other vaccines will be taken into account in our analyses. Next slide. This figure depicts a typical pregnancy divided into 3 trimesters. The pregnancy start date is typically the last menstrual period. In the next 4 slides, I will review pregnancy outcomes and expected timing for the RSVpreF vaccine during pregnancy. Next slide. The first row above the pregnancy timeline shows various live birth outcomes. Prior to 20 weeks gestation, pregnancies are considered non-viable, and from 20 through 26 weeks, peri-viable, meaning there is a reasonable chance of extrauterine survival. Any pregnancy ending before 37 weeks gestation in a live birth is considered a preterm birth. Live births at gestational age 37 weeks or after are considered term deliveries. Next slide. The top row shows intrauterine fetal demise outcomes. These include spontaneous abortions, which can occur up to 20 weeks gestational age, or stillbirths, which occur at 20 weeks gestation or later. Next slide. The yellow box shows the time period during pregnancy when the RSVpreF vaccine has been approved for use. When considering pregnancy outcomes and the RSVpreF vaccine, only outcomes that are possible will be included. Next slide. We will not include spontaneous abortion, as it is not a possible outcome because of the timing of vaccine and pregnancy. Next slide. Our primary approach for prenatal RSVpreF surveillance will be through bi-monthly surveillance. We will use validated algorithms applied to electronic health data in the VSD population to identify pregnant persons 16 through 49 years of age at 20 weeks gestation or later. We will exclude pregnancies ending in therapeutic abortion, multiple gestation pregnancies, and those with insufficient information to determine the start date of the pregnancy. The exposure we are evaluating is RSVpreF vaccination at or after 28 weeks gestation. This is to account for any inaccuracies in gestational age estimation. We plan to match pregnant persons vaccinated with RSVpreF to pregnant persons unvaccinated 1-to-1 based on VSD site and gestational age at vaccination. We will create propensity scores to account for confounding using readily available variables such as pregnant person's age, pregnancy start date, race, ethnicity, and medical comorbidities. Next slide. Adverse outcomes evaluated include both acute outcomes and pregnancy-related and birth outcomes. I will show a list of the acute outcomes evaluated on the following 2 slides. These outcomes were chosen based on biologic plausibility and data from clinical trials, as well as being used in prior vaccine safety studies. To identify these outcomes, we will use an algorithm developed for other VSD safety surveillance work, which has been modified for a pregnant population. The algorithm uses diagnoses associated with outpatient, emergency department, and hospital encounters. Chart confirmation will be used for selected outcomes. The pregnancy-related and birth outcomes we will evaluate include preeclampsia or eclampsia, which will be based on ICD-10 codes, preterm birth based on the gestational age at birth, and stillbirth, which will be identified from ICD-10 codes, then chart reviewed for confirmation. Next slide. This slide and the next show the acute outcomes we will be monitoring following vaccination. The table has the outcome listed in the left column, followed by the risk window during which each outcome will be evaluated for, and the VSD background rate per 10,000. These background rates are based on data from our COVID-19 studies using the rate in the unvaccinated group. The risk window for anaphylaxis is limited to the day of and first day following vaccination and will only be studied in the vaccinated group. The next three outcomes, fever, malaise fatigue, and skin and soft tissue or local allergic reactions, are limited to 7 days following vaccination. All other outcomes listed alphabetically will be evaluated during both 1 through 21 days and 1 through 42 days following vaccination. Next slide. This slide is a continuation of the previous slide. Next slide. This table shows the pregnancy-related and birth outcomes we will evaluate. The outcome is listed in the left column, followed by the risk window during which each outcome will be evaluated for, and the number and percentage of vaccinated clinical trial participants who experienced the outcome from the phase 3 RSVpreF clinical trial. The outcomes we will evaluate are preeclampsia and eclampsia, preterm birth, and stillbirth. We will evaluate preeclampsia, eclampsia, and stillbirth at 1 through 21 and 1 through 42 day intervals following vaccination. The risk window for preterm birth will vary based on the age at vaccination and will end at 37 weeks gestation, as births after 37 weeks gestation are considered term. The percentages shown for the RSVpreF phase 3 trial are based on all study participants for preeclampsia, eclampsia, and stillbirth. For preterm birth, we use the rate from high-income countries as this seemed most applicable to our VSD population. Next slide. For the analysis, we will determine risk ratios with corresponding 95% confidence intervals using Poisson distribution with robust variance using a generalized estimating equation. Censoring within risk windows will be applied when an individual is no longer at risk for the event, once a pregnancy outcome occurs, or if an unvaccinated match is vaccinated. We will include adjustments for known confounders. If a preterm birth signal is detected, we will perform further exploration into the etiology. We plan to perform a sensitivity analysis using alternative matching strategies. Because the RSVpreF vaccine is recommended for use during the same time period when Tdap is recommended, we will explore whether it is possible to evaluate co-administration of both Tdap and RSVpreF. Next slide. This slide shows an example timeline for our planned bi-monthly surveillance. If vaccinations start in October, we would plan to capture 2 months of vaccinations followed by a 42-day follow-up period and a 2-month data lag before pulling any data. Our first data pull would be in March of 2024. We will continue bi-monthly surveillance every 2 months. Next slide. Thank you to everyone who has contributed to this planned surveillance. I'm happy to answer any questions.
Thank you, Dr. De Silva. We are going to actually take questions after Dr. Moro's presentation. So if you stay on the line, that would be wonderful. We're going to move on to Dr. Pedro Moro from CDC, who will be presenting on the Maternal RSV Vaccine Safety Monitoring in VAERS and V-safe. Dr. Moro?
Okay, well, good morning. So I'll be describing the Maternal RSV Vaccine Safety Monitoring in the Vaccine Adverse Event Reporting System and VSafe. The next slide, please. So I'll start with VAERS. So VAERS is a national passive surveillance system, which is the frontline surveillance system that monitors all licensed vaccines in the United States. And it is a system that was created back in 1990, and it's co-managed by CDC and the FDA. The next slide, please. So this slide shows some of the strengths and limitations of VAERS. And among the strengths, 2 important strengths is that it can rapidly detect safety signals, and it can also detect very rare adverse events. It has a number of limitations, and one important one is that it's not designed to assess for causality. But VAERS is a hypothesis-generating system that can identify potential vaccine safety concerns that can be studied in more robust systems. The next slide, please. So this slide shows some of the approaches that can be used to analyze VAERS data in pregnancy reports, and that's what we plan to do for RSV. But I should say that for more than a decade, VAERS has been used as part of vaccine safety surveillance for vaccines used in pregnancy, such as influenza, Tdap, and COVID-19. So one type of analysis is a descriptive analysis, which includes clinical review of individual reports, aggregate descriptions of automated data, which involves counts of reported adverse events, and also calculation of reporting rates for pregnancy outcomes. And this can be done if there are doses of RSV vaccine administered in pregnancy, or if there's data on vaccination coverage. Now, statistical analyses may be done. Historically, the approach has been to use data mining to assess for disproportionate reporting, and this is under discussion right now for RSV vaccines. The next slide, please. So, in order to find these pregnancy reports, we have to search for them in the VAERS database. And this search of reports involves a number of strategies, which are shown in the first three sub-bullets in the slide. So one involves looking for some three specific MEDRA codes for pregnancy. Another approach is to look for an affirmative answer to question 8. Question 8 asks the patient whether they were pregnant at the time of vaccination. And then we'll also do a string search of text fields in certain variables for the term preg. So we're going to use all of these to look for these pregnancy reports. And we will also do a medical records request for all pregnancy reports, both serious and non-serious. And clinicians will review these reports to confirm that they are pregnancy reports and also to categorize the main adverse event of interest. The next slide, please. So VAERS is going to follow up is going to conduct surveillance of certain adverse events of a special interest after RSV vaccination. And there are these primary ASIs, as we call them, and secondary ASIs. The primary ASIs have been selected for historical reasons, but also because some of the conditions were observed in the pre-licensure clinical studies of RSV. Now, for these primary ASIs, VAERS will obtain medical records for all reports, and CDC will review records and abstract clinically important information. And now ASIs may be added or removed, depending on the how much reporting we see. If we see an unexpected reporting of an adverse event that was not expected, then we'll certainly put in maybe in the primary ASI list and monitor that more carefully. Now, secondary ASIs will be monitored periodically through automated data tables, but the information will not be abstracted. But again, if we see that there is a secondary ASI that is being reported very frequently, and there is suspicion of a safety concern, that we may put that in the primary list and monitor that more carefully. The next slide, please. So this slide shows the listing of the primary ASIs, the conditions under primary ASIs and also secondary ASIs, and you'll know that for the primary ASIs, for example, under neurological conditions, there are some of these conditions were observed in the pre-licensure studies of RSV. The next slide, please. And pregnancy specific outcomes will be monitored in VAERS and abstracted after maternal RSV vaccine. So this will be monitored very closely and the information abstracted. The next slide. Now, with regards to VSafe, is a new version of VSafe developed starting summer of 2023. And this system leverages existing CDC IT infrastructure. It includes email and text messaging options. And is the first use for RSV vaccines received by persons aged 60 and older. And use of maternal RSV vaccine is planned to be monitored later this fall. VSafe objectives include characterization of local and systemic reactogenicity during days 0 to 7 after vaccination, characterize health impacts during a 6-week post-vaccination follow-up period, and also identify participants who report medically attended events after vaccination and encourage completion of a VAERS report. And I believe that's the last slide. Thank you.
Thank you, Dr. Morrow, and thank you, Dr. De Silva. These two presentations are now open for questions. Dr. Paling.
All right, good morning. I actually have a question for both of our speakers. First of all, I want to say thank you for sharing the plans to proactively look at the vaccine safety. That is really important. And for Dr. De Silva, one of the questions I have for you in the safety vaccine safety data link is how are you planning to handle pregnancies with multiple gestations, the twins, the triplets, etc., as they are at risk for additional preterm births? Thank you.
Thank you. We, for this initial planned evaluation, we have excluded them. As you mentioned, they are at higher risk for preterm birth. We are planning a more comprehensive and season evaluation, and we'll consider how to account for multiple gestation births in that as well.
Okay, wonderful. And then my question for Dr. Morrow. Thank you for sharing about the VAERS and its limitations and strengths, as well as the V-safe and the new version. It's really exciting to hear about that. Could you please share? We understand this new version is just being rolled out for the RSV vaccine for 60 years and older. And could you share some of the experience that you're aware of to date? Thank you.
I don't know if Dr. Shimabukuro is on.
Maybe.
Yeah,
Dr.
this is Dr. Shimabukuro. Is wondering if someone from the VSafe program is on the line.
Hi, this is Ann Hawes from
Yeah.
VSafe. I can take this question.
If you could just give a status update. I don't believe we have any actual data right now, but just a program update. Thanks.
Sure. So the new version of VSafe is still in the final stages of development. We do plan on launching this fall and evaluating the RSV vaccine for older adults first. And then later this fall, we hope to launch for the maternal RSV vaccines. So no data yet.
Thank you. And I think the other implicit question that Dr. Paling was asking was just nothing of note from VAERS regarding the older adult population. I'm guessing we haven't had enough doses in, but Dr. Shimabukuro, if you could just let us know, that'd be great.
We're monitoring and we are receiving reports, a small number of reports, but we haven't seen any unusual or unexpected patterns at this point.
Thank you, Dr. Shimabukuro. Dr. Bell.
Good morning, and thanks for the presentations. This question is for Dr. De Silva. I'm wondering if anybody has done any sort of I'm interested in when we might be able to see some data. And so I'm wondering if anybody's done any back of the envelope calculations using different assumptions for uptake, understanding what you would expect in terms of accrual of pregnancies in your database, and, various estimates of power and such to give us some sense of how long you think it might take, depending on what happens with uptake, to have some useful results from the VSD. Thank you.
At this time, with the uncertainty about the vaccine uptake and while we're awaiting recommendations for use, we anticipate we'll be well powered to detect significant differences in preterm birth within 6 months of vaccine eligibility. Additionally, we are planning to perform some preterm and stillbirth surveillance that will be separate from this planned bi-monthly surveillance. This would only be descriptive. And while it's descriptive, it would be limited to the vaccinated population and can be performed slightly more quickly, but it would be needed to be noted that these results will lack a control population, still require a data lake similar to other VSD work, and would not include any statistical comparisons. So it's still going to be a little bit of time. So, but we do think we'll be well powered within 6 months.
Great, thank you. It's really helpful.
Thank you. Dr. Sanchez?
Thank you. And I'm excited to know that V-safe will be also utilized for this vaccine as well, if it is recommended and approved. I had a couple of questions for Dr. De Silva. In your slide 16, I'm just where you compare the pregnancy-related and birth outcomes. Just clarification, will you be comparing preterm births to what was seen in the Pfizer phase 3 trial, knowing that in the Pfizer phase 3 trial, the women enrolled were at low risk for preterm births? And we're going to be possibly recommending a vaccine to all women who certainly our preterm births are much higher.
No, it's because of this that we're not comparing to this clinical trial population. We know they're at lower risk for preterm birth and for the other events that are listed on this slide. So we would not be, this is just to show what was seen in the clinical trial, but we do anticipate that the results we see are going to be different from this. Thank you.
And then another question, with simultaneous vaccination with the vaccine, RSV vaccine with the, with Tdap was associated with lower pertussis antibodies, and we don't know the clinical significance of that. Will there be any monitoring of infant pertussis infection in the first 2 months of age?
The Vaccine Safety Datalink focuses on the safety and not necessarily the effectiveness of the vaccine. So I would look to other CDC colleagues to speak about what other studies are being done or monitoring is being done for effectiveness of the vaccinations.
So I think it would be important with all of these vaccine safety and effectiveness consortiums, I think that would be an important outcome to look for. Thank you.
Thank you. I don't know if there'll be a response from the room, but I actually have a couple more questions. One, this is for Dr. De Silva. For the VSD background rates you mentioned for the non-pregnancy outcomes, do you have a sense of whether those are obtained from the general population or from pregnant people? And I ask partly because some of the outcomes may be have slightly different background rates in pregnant people.
The background rates that I presented on slides 14 and 15 are from the monitoring we did in the pregnant population for COVID vaccine. So it was an all pregnant population.
Okay, terrific. Thank you so much. And then the other question, and I realized, so first of all, I have to commend you for the elegance of the study because it's a very complicated design. And we really appreciate the ability of our systems to be able to even conduct this kind of surveillance, which is not simple by any means. But I'm going to ask a hard question anyway, which is there a way to capture other illnesses that happen during pregnancy, whether they're concomitant or not, respiratory or febrile illnesses, knowing that those also potentially place pregnant people at risk for some of these pregnancy outcomes?
We will capture medically attended events. So if it rose to the level of seeking medical attention, we would have some information about that. It would be dependent on how the provider codes for what they're seeing. And so we are limited in that sense. And we can consider how to potentially include some additional covariates such as diagnosed respiratory illnesses, especially if there's testing involved. But that hasn't currently been added as part of this surveillance.
Thank you. I mean, maybe even if it's, as you're looking into charts, it would be helpful to capture that information systematically. I think that would be useful too. And then one last question, as you had mentioned, and actually this also applies to Dr. Morrow, concomitant vaccines will be helpful to capture. Will you also be able to capture flu vaccines for those pregnant people who might be getting all three in terms of timing?
I think we'll be doing descriptive looks and considering how we might be able to look at all these different co-administrations. It's going to be complex given that we're not sure if they'll be administered at the same time or within the risk windows. So we're trying to think through exactly the best way to look at this.
Okay. Thank you. I appreciate the numbers may be small, so you may not be able to infer anything, but just even capturing the descriptive information, I think would be incredibly helpful. So we appreciate that. Dr. Morrow, will the VAERS team also be able to, and VSafe team be able to capture concomitant or other vaccines, as well as respiratory or febrile illnesses?
Yes, VAERS should be able to. It does capture other vaccines received at the time of vaccination with RSV.
Thank you. Okay. Dr. Link-Ellis, did you want to make a comment or respond?
Yes, sure. I can respond to the question earlier about vaccine effectiveness.
And apologies if it isn't you, but I'll just call on my colleagues in the room at the CDC.
Yes, I can respond to the question earlier about vaccine effectiveness. So we have a number of plans in place to study post-licensure effectiveness of maternal RSV vaccine, and we work closely with the pertussis group here at CDC. I will say generally getting one vaccine is predictive of getting another vaccine, so it becomes very difficult to find people who got only pertussis, for example, or only RSV. So looking at co-administration with real-world data can be difficult, but we do have a number of plans in place to attempt to do that.
Thank you, Dr. Link-Ellis. Ms. Hayes.
Yes, good morning. Carol Hayes with the American College of Nurse Midwives. In my experience with the COVID vaccines, the vast majority of the time when I received one in a public setting, like in a pharmacy or a grocery store, I was never informed of VSafe. There was no paperwork included. So I would just like to put in a request that the team that's working on VSafe do some kind of campaign with the chain pharmacies and the grocery stores and with ACOG and ACNM to promote VSafe, because I think it is such an incredibly valuable tool for monitoring side effects from the vaccine and other things. And so I just want to put that plug in. Thank you.
Thank you very much. Any other questions? Okay, well, we want to thank Dr. De Silva and Dr. Morrow for their presentations today on vaccine safety and appreciate again the proactive stance towards vaccine safety monitoring, especially in our pregnant populations. Next, we'll move on to the economic analysis section. We are a little ahead of schedule, but I think we're just going to keep going. So in terms of the first presentation is Dr. David Hutton from the University of Michigan, who will present on the economic analysis of RSVpreF maternal vaccination. Dr. Hutton, the floor is yours.
Great, thank you very much. And let me know if we have any technical issues here. So thank you for the opportunity to present again today. This is an update on the economic analysis of RSVpreF maternal vaccination. Next slide. The research team here is collaborative research with people from the University of Michigan and CDC. We have no known conflicts of interest. On the next slide here. So some updates since the June 21st presentation. We have an additional vaccine efficacy scenario. We've also added some additional timing scenarios where the vaccine might be administered in specific months of the year. And we're now evaluating administration from weeks 30 through 32 through week 36, the end of week 36. We also have an updated cost per dose of the vaccine. Next slide. Remember, this is our initial efficacy. This has not changed. It has the sigmoid downward sloping efficacy during the first 6 months, and using the average efficacy during this period is based on average 6 months efficacy. We have two different efficacies here, one against hospitalization and ED visits and one for outpatient visits. The hospitalization efficacy is based on hospitalization efficacy from the trial, and then efficacy against outpatient visits is based on efficacy against medically attended lower respiratory tract infections. Next slide. We also evaluated a scenario with flat efficacy here during those 6 months and then back down to 0 after that. So both this one and the previous one, we assume 0 efficacy after 6 months. But there's a new scenario, which is on the next slide. The new scenario on the next slide here is more optimistic. It has a slightly higher efficacy in those first 6 months. The efficacy against hospitalization here is based on efficacy against severe medically attended RSV lower respiratory tract infection observed in the trial. So that's slightly higher efficacy than we use in our base case. And then in addition, in this optimistic scenario, we assume there's declining efficacy from months 6 through months 9. So a longer period of efficacy slightly there from periods month 6 through month 9. Next slide. Also, in our base case, we look at RSVpreF given year round, but we have some new scenarios here today. One, I'll show cost effectiveness if we give RSVpreF during specific months of the year, and then some other scenarios where we look at RSVpreF being administered in specific ranges of months throughout the year. Next slide. Another change here is that the vaccine is given from the beginning of week 32 through the end of week 36 of the pregnancy. That's a little bit narrower range than was done in the trial, but that's kind of what the FDA has settled in on. We assume here that the vaccine must be given within 2 weeks before birth for the vaccine to confer protection. So if the baby is born within 2 weeks of administration, we assume no efficacy of the vaccine. And then on the next slide, we'll show a visual of that. So we assume we have, let's say for 100 persons, for 100 pregnancies here, we assume 50 would intend to vaccinate, but only 48 would actually get vaccinated because 2 might give birth before that, week 32 roughly time frame. And then of the 48 that are vaccinated, there would be about 3 or so that would be vaccinated within 2 weeks of delivery. So we end up with kind of 45 effectively vaccinated in time. When I say in time, that's again, 2 weeks or more before delivery. Next slide. So a few updates to our base case here. In June, I presented numbers based on 1,000 births. Today, I'm going to present results based on the entire U.S. birth cohort per year. We're assuming 50% uptake with the RSVpreF vaccine. We're looking at this just over 1 RSV season. And the other big update here is that we're using a $295 per dose cost. That is an increase from the $200 a dose estimate we had in June. So it's a significant increase in the price per dose. Okay, so let's look at some results here. On the next slide, we have number needed to vaccinate. This is very, very similar to what was shown in June. It's about 4% higher because of the later timing of vaccination in weeks 32 through weeks 36, which means slightly more people get vaccinated within those 2 weeks of birth. But basically, this is very, very similar to what you saw in June. On the next slide, we have some cost information. The total costs here are higher because we're looking at a larger cohort. This is the entire U.S. birth cohort than what we saw in June. But the relative positioning of the heights of these bars are very similar, except for that second bar of RSVpreF, the intervention cost, that is higher, relatively speaking, because the vaccine price per dose increased by about 50%, a little less than 50%. Okay, let's look at the next slide here. Cost per event averted. These cost per event averted are also higher than what I showed in June because the price per dose is about 50%, a little bit less than 50% higher than what we had assumed in June. So for example, to avert an inpatient stay would be about $68,000 per inpatient stay averted. Let's move on to the next slide for the cost effectiveness results. So the new incremental cost effectiveness ratio here is now about $400,000 per quality adjusted life year gained. And this is mainly driven by that increased cost of the vaccine dose compared to what we saw in June. On our next slide, we have some sensitivity analyses here. This is a tornado diagram, again, showing how various changes in the assumptions will change the incremental cost effectiveness ratio. We have similar rankings of which parameters are most important, as we saw last time. Prematurity could potentially dramatically increase the incremental cost effectiveness ratio, although hopefully that's less likely with a later administration of RSVpreF. The quality of life impacts of RSV also have a large impact on the incremental cost effectiveness ratio. That's something we're pretty uncertain about. The vaccine price is an important driver of cost effectiveness. The cost of inpatient care also can have a large impact on the cost effectiveness of vaccination, and vaccine efficacy can also have a large impact on cost effectiveness. Okay, let's look at the next slide here. One of the scenarios was varying how we modeled the vaccine efficacy. So this is what happens if we have that flat efficacy. If we assume that flat efficacy, the incremental cost effectiveness ratio is about $365,000 per quality adjusted life year gain. And then finally, the new scenario on the next slide is that more optimistic efficacy scenario, slightly higher and longer efficacy. Because of that, it can have a bigger impact, and the incremental cost effectiveness ratio under this scenario here is about $286,000 per quality adjusted life year gain. On the next slide, I'll show you this is a little more complex graph here. It's showing the combined impact of hospitalization costs, which we said were important, RSV mortality, which can be important, and vaccine efficacy, which I just showed you, that more optimistic efficacy. And it's all showing you that on the same graph. There's a lot going on here. As we move from left to right on the x-axis, the hospitalization cost increases. Our base cost is about $11,000 per hospitalization. But here, if we think it's much, much higher, the cost effectiveness ratio would drop as we move to the right. If we have a more optimistic vaccine efficacy, which are the orange lines on this graph, that's the graph I just showed you, with the higher and longer efficacy, the cost effectiveness ratio drops here as well. And also if RSV is more deadly, which is the dotted lines, so instead of having 0.1% risk of dying in the hospital, it's a 1% risk of dying in the hospital. Those are those dotted lines. Then the cost effectiveness ratio drops here as well. So there's a lot kind of going on in this slide. Let's look at the next slide, which is a much simpler slide. This is just highlighting again that the cost per vaccine dose can have a big impact on cost effectiveness. Again, with a base case price of $295 per dose, we're close to $400,000 per quality. But if the vaccine cost per dose were lower, then the cost effectiveness ratio would drop as well. Next slide, I want to show you just remind you of some timing scenarios. Everything I've just showed you is assuming that the vaccine is given year round. But now I want to look at things by month and by specific ranges of months. So the next slide shows us the cost effectiveness ratio if RSVpreF is given in a particular month of the year. Recall, that RSV is very seasonal, and there are a lot of infections in the winter time. And if RSVpreF is given right before winter time, and so it has its 6 months of efficacy right during that peak, the cost effectiveness ratio dramatically decreases. So if RSVpreF is given in months like February through July, the cost effectiveness ratio is over $500,000 per quality. However, if it's given in, let's say, October or November, the cost effectiveness ratio is in the range of $115,000 per quality or so. So the cost effectiveness ratio can be dramatically lower if it's given right before the peak of the RSV season. Okay, let's look at the next slide here, and we'll look at some ranges of months. So just recall the base case was about $400,000 per quality if given year round. And here we have different ranges of year about when the RSVpreF vaccine would be given. And so again, if we look at the far right here, a very limited range of time, a time window for RSVpreF given. If it were given September through December, for example, the incremental cost effectiveness ratio would be $141,000 per quality or so. Okay, so just to recap here on the next slide, some limitations here I do want to mention, and these are very similar limitations to what you saw in June. The model structure doesn't include risk groups or dynamic transmission. Also, this is a new vaccine, and actually we still have uncertain epidemiology of RSVpreF, so we're uncertain about RSVpreF costs, the qualities lost from RSV. We're uncertain if we are actually going to impact upper respiratory tract infections, and we're still uncertain about prematurity. So there are a lot of things we're still uncertain about that affect our results. We're also assuming we're not, in this, everything I've showed you so far, we're assuming no infants will be receiving nirsevimab. So this is just assuming that none of them will be receiving nirsevimab. So in the next slide here, I just want to recap the summary. RSVpreF may improve RSV outcomes, but also will increase costs. RSVpreF has the potential to be cost effective, and results are sensitive to a wide variety of assumptions. Let's go on to the next slide though. And everything I just showed you was assuming no one's getting nirsevimab at all. But of course, many people may be getting nirsevimab. So the next thing I want to show you here are the economics of combined use of maternal RSVpreF vaccine and nirsevimab. On the next slide here, we have the study questions. Again, we're asked, nirsevimab has been recommended. So now we want to think about combinations of RSVpreF and nirsevimab. And so we'll answer kind of two questions here in the next few minutes. One is, if we know that RSVpreF has been administered in time, how cost effective is it to also provide nirsevimab? And the second question is, if we know the infant is definitely going to receive nirsevimab, how cost effective is it to encourage RSVpreF vaccination for the pregnant person? Okay, so in the next slide here, we have some updates since June. Now RSVpreF, we're assuming it's going to be administered weeks 32 through the end of week 36. We're also assuming that mainly all these infants will be born full term, and so we're not going to assume that there's any need for palivizumab. We're also going to consider some higher risk populations, but this is going to maybe kind of confusing. These are high risk, but not premature populations. And we're also considering new timing of RSVpreF administration. Okay, let's look at the next slide here. Just quickly, we really have no evidence of efficacy on the combined use of these products. There are no trials on that. So we have some assumptions here about, and this is the same assumption we had in June here. Efficacy is equal to the highest of whatever would be effective at that particular time, nirsevimab or RSVpreF. So just whichever is higher, there's no kind of combined synergistic efficacy. So on the next slide, we can see that visually. So assuming administration of nirsevimab at birth to someone who had received RSVpreF, the additional efficacy would be this kind of gray area when nirsevimab would give additional efficacy on top of what RSVpreF would give you. And that's if things are given at birth. On the next slide, we see, again, what would happen if, let's say, the baby was born in August. They'd have some RSVpreF efficacy. And then if you added nirsevimab on top of that in October, you'd see a bump up in efficacy, and the additional benefit would be kind of what's shown in gray here. And just as a reminder, peak infections are typically in that December to February timeframe, and so you'd want to have additional efficacy during that peak timeframe. Okay, on the next slide, again, I want to highlight that we're just looking at the incremental benefit. We'll start off looking at the incremental benefit of adding nirsevimab on top of someone has received RSVpreF. So RSVpreF is received at least 2 weeks prior to delivery. Next slide here. I just want to highlight we're also going to look at higher risk individuals. And when I say higher risk, it's just a multiplier on their risk of hospitalization. It doesn't affect anything else like outpatient ED incidents, costs of outcomes, and so forth. It's just an increased risk of hospitalization when I say high risk. Okay, so the next slide here is going to show us the incremental cost effectiveness ratio based on the month of birth and the risk level. So the different colored bars represent different risk levels, and then the different months of the year are shown here. I just want to highlight also nirsevimab would be given at birth, October through March. And if we assume the baby's born in April through September, they would not be given nirsevimab at birth, but they'd be instead given it at the start of the RSV season in October or November. We can see a few things here. The incremental cost effectiveness of adding nirsevimab looks better if it's given to those babies born April, May, June, July, August, September, and then nirsevimab is given right at the beginning of the season here in October, November, the cost effectiveness ratios are much lower. And the other thing you'll notice here is the cost effectiveness ratios are lower for infants who are higher risk. So infants who have 3, 6, 10 times the risk of hospitalization, the incremental cost effectiveness ratios are much lower. It's much more valuable to give them nirsevimab on top of RSVpreF. Okay, the next slide just really highlights that. Here I've taken out the risk levels of 1 and 2 to make it a little bit easier to see here precisely what these cost effectiveness ratios might look like for the 3 times, 6 times, and 10 times risk. You can see that particularly for babies born in the summer and the nirsevimab given at the beginning of the season, the cost effectiveness ratios look pretty good, below $150,000 per quality and lower, and even potentially for higher risk individuals born during the season, nirsevimab given at birth, the cost effectiveness ratios might look good for the higher risk populations. Now let's look at the next slide here. This is looking at the number needed to immunize here, and this is assuming that we would provide nirsevimab year-round. This is number needed to immunize. Notice, for example, to avoid an inpatient visit for an average risk child, this would be the 1 times risk. That's the dark blue bar. Inpatient, it would be over 200 infants needed to immunize to avoid 1 inpatient visit if you're giving nirsevimab year-round to vaccinated mothers. And let's go to the next slide here, which is the cost effectiveness of adding nirsevimab to all infants born year-round. So it would be quite expensive for people who are average risk. That's the dark blue bar at the left, $400,000 per quality adjusted life year. But providing nirsevimab to infants born to vaccinated mothers, if they were 6 times the risk, for example, here the yellow bar, would be about $40,000 per quality adjusted life year gained. So there might be it might be cost effective to provide nirsevimab in addition to RSVpreF for those high risk infants. Okay, and the next slide, I want to show a different scenario here where we maybe limit giving nirsevimab just to infants born in April, September. Now they wouldn't be given nirsevimab at birth. These are the infants that would get nirsevimab at the beginning of the RSV season in October, November. Here, the number needed to immunize is similar, but slightly lower than what I showed you if we're giving nirsevimab year-round. And then let's go to the next slide and see the cost effectiveness ratios here. You can see the cost effectiveness ratios drop. It becomes more cost effective to provide nirsevimab to those infants born April through September, giving nirsevimab at the beginning of the RSV season here, about $300,000 per quality to do that for all infants of all risk levels, and much more cost effective to give nirsevimab to the RSVpreF infants if they're higher risk, like 3, 6, and 10 times the risk. Let's look at the next slide here. And here's a different scenario of those giving nirsevimab at birth for those children born October through March. Here you can see the number needed to immunize is higher, of course, because they already have a lot of RSVpreF protection during that time period. And the next slide here is showing the cost effectiveness ratios. So we see about $600,000 per quality, for example, if we're giving this to average risk babies born October through March, who also had RSVpreF protection. So it's less cost effective to also give them nirsevimab on top of their RSVpreF protection. So the next slide here is just a very brief summary. The incremental benefit of adding nirsevimab on top of a baby who's already got some sort of RSVpreF protection. There is some additional benefit. The cost effectiveness ratios are high, but they could be lower for higher risk populations, particularly if they're born off peak. Okay, on the next slide, I just want to briefly talk about the incremental benefit of adding RSVpreF on top of nirsevimab. So if you know the infant will definitely be receiving nirsevimab, how valuable is it to encourage the person who's pregnant to get the RSVpreF vaccine? And the next slide shows the cost effectiveness ratios here. These are very high. This is similar to what we saw last time, over $10 million per quality for many months of the year. The best month of the year most in terms of cost effectiveness is still $2.4 million per quality if you give RSVpreF to babies born in April, if they're definitely also going to receive nirsevimab. So the incremental cost effectiveness ratios here are quite high. And just so in the next slide here, if you know the babies are going to receive nirsevimab, there's very marginal additional benefit beyond that nirsevimab protection that's conferred by RSVpreF protection, and these incremental cost effectiveness ratios are extremely high. So just in the next slide here, I just want to recap some summary here. Limitation, I want to highlight again, there's no efficacy data on these combined products, so these are all based on assumptions about what the efficacy might be. Nirsevimab may add additional protection on top of RSVpreF, particularly for higher risk infants, and then adding RSVpreF on top of nirsevimab does only really add marginal effectiveness at a very high cost to the population. And that is it. Thank you very much for your time here, and I'm open for any questions you might have.
Thank you, Dr. Hutton, for that excellent presentation. We are going to try and take questions for both presenters, so please stay tuned. We're going to move on to Dr. Ismael Ortega-Sanchez, who will present on the economics of preventing RSV disease among U.S. infants by maternal vaccination prior to birth.
Good morning. My name is Ismael Ortega-Sanchez. I am the Senior Economist of the NCIRD. This morning, I will attempt to compare and summarize the key elements and findings of two economic studies dealing with the economics of preventing respiratory syncytial virus disease among U.S. infants by maternal vaccination prior to birth. In the last 8 to 9 months, the two models were updated several times. In this summary, I will focus only on the vaccine, so there will be no discussion about the last component of the presentation of Dr. Hutton regarding the nirsevimab. As we said, they were also discussed in extensions in the maternal and pediatric RSV ACIP working group. Next slide, please. The first of these studies have been conducted by Pfizer. Pfizer is the manufacturer of bivalent RSVpreF vaccine. I will refer to this as the Pfizer model in dark blue. The second is an analysis led by Dr. Hutton. You have just seen a summary and updated before this presentation, and their colleagues from the University of Michigan. They are collaborators from CDC, and I will refer to this as the CDC model in light blue. For full disclosure, I have been part of the team conducting the CDC model. Next slide, please. The starting point of the two economic models is the policy question regarding potential recommendations for the use of RSV vaccine in pregnant mothers. To consider the economics of the policy question is to consider simultaneously the health benefits and costs of vaccination. Namely, is vaccinating pregnant mothers prior to birth to protect infants against RSV disease cost effective? To address this question, the two models use the same comparator, unvaccinated mothers and the standard of care for infants. And then they focus on analyzing the cost effectiveness of vaccinating pregnant mothers, 32 to 36 weeks of gestation age, at least 2 or more weeks prior to the birth with RSVpreF vaccine. Next slide, please. The policy question has important implications for 3 groups of elements, namely the comparison of the two economic models will focus on how appropriate is the selection of the modeling approach, the inputs for RSV disease burden, vaccine efficacy, and costs, and how strong and influential assumptions were made in order to come up with the outcomes. Next slide, please. In general, the two models follow similar designs. The two use a static analytical decision-making approach, relied on probabilities or deterministic sensitivity analysis to manage the various data uncertainties, model hypothetical birth cohorts in the United States that corresponds with the number of pregnant mothers in the cohort. The time frame was defined as the first year after birth. They also account for loss of income associated to temporary productivity loss and to the loss of premature RSV-associated deaths. Next slide, please. Once the modeling strategy was set, the two models were fed by different types of input data: clinical, epidemiological, economic, quality of life, vaccine characteristics, and so forth. Across models, the source-specific values and assumptions of these parameters have some overlaps, but there were marked differences as well. For the consultation of ACIP members, the full input list could be made available. Back to this slide, in the boxes are listed the standard outcomes estimated and reported by the two models. We'll focus mostly on the cost per quality safe, and I want to emphasize that once the models are built this way, we have to go in reverse in order to go first with the outcomes and then analyze what happens with the inputs. Next slide, please. This slide presents the report card of the CDC model. It is a summary of the main cost ratios and health outcomes. Among the reported outcomes, we have the base case estimate for the vaccinating pregnant mothers in the vaccination window of 32 to 36 weeks of gestational age, year-round, to be around approximately $400,000 per quality safe, when vaccine costs are $295 per dose. Additionally, the CDC model reports costs per prevented specific health events and the number needed to vaccinate to prevent a hospitalization, an emergency department visit, an outpatient visit, and a number needed to vaccinate to prevent a death associated with RSV LRTI. Next slide, please. Similarly, this is the Pfizer summary report card. Among the reported outcomes in the summary card, we have that the base case estimate about $85,000 per quality, with the vaccination window the same, similar to the CDC, 32 to 36 weeks of gestational age, year-round vaccination, and when the vaccine cost is $295 per dose. Pfizer cost per quality finding is supported with its simulation and sensitivity analysis when simultaneously varying the input and variables in the model. As you can see, most of these simulations included in the base case, in the figure on the right-hand side, come back being somewhat costly, but with gains in qualities, as represented by the blue dots within the first quadrant. Lines from the origin indicate the percentage of simulations with cost and effectiveness estimates that fall below a given value. For example, 65% of the simulations in the Pfizer model had a cost-effectiveness ratio that was less than $100,000 per quality, which is represented by the line in the middle of the three ones. Next slide, please. Even though both models assume equal vaccine cost per dose, vaccination window of 32 to 36 weeks of gestational age, a year-round vaccination administration, the CDC results cost per quality are still much higher than those of Pfizer. Specifically, the CDC estimates of the cost per quality and the cost per hospitalization adverted are about 5 times higher than those of Pfizer and 10 times higher for the cost per death prevented. When we move away from the cost ratio, the difference in number needed to vaccinate ratios persists, though the differences are relatively much smaller. The CDC model reports a 65% higher number needed to vaccinate to prevent hospitalization and a 300% higher in the number needed to prevent an RSV-associated death. And the first takeaway for the committee, both models agree that maternal vaccination will be relatively costly, but it will also prevent lower respiratory tract infection, hospitalization, and safe qualities among infants and caregivers. The question begins about why is the difference in costs and the ratios of number needed to vaccinate. Next slide, please. To understand these persistent discrepancies, we try to identify the sources of these differences. Here, the CDC model provides a one-way sensitivity analysis. This is the same figure that you have seen a minute ago by Dr. Hutton. The tornado figure helps to identify and rank the most influential input variables from the top to the bottom. The solid vertical blue line describes the base case cost per quality value, and each horizontal bar represents the input variables in the model. The size and direction of the horizontal bars describes the influence of each input and when it's at its highest or lowest. Note that after probability of prematurity ranked first, which is something that we expect not to happen, comes the qualities lost. Also ranked high is the medical cost, followed by vaccine efficacy for hospitalization. Next slide, please. In a similar fashion, Pfizer does also report one-way sensitivity analysis on some scenarios where the most influential variables are identified from the right, with the high bars, to the left with the low bars, with the base case in scenario number 7. Note that among the most influential variables are vaccine efficacy, followed by medical cost for hospitalization, vaccine duration of protection when it's truncated at 6 months, and the case fatality rate among hospitalized infants with RSV LRTI. Next slide, please. Except for RSV hospitalization risk and seasonality and vaccine-associated adverse events, the other elements that are listed here were identified from the tornado figure. So therefore, we're going to be focusing a little bit more in terms of the initial vaccine efficacy and waning over time, the unitary medical costs, the case fatality rate, and the quality of life lost by patients and caregivers. In the following slides, we will explore more these inputs and as explanatory factors of the difference in outcomes. Next one, please. First, let's get rid of two elements that do not explain these differences. As shown in the figure, the risk of hospitalization on the right-hand side and the RSV seasonality on your left as input data used in both of Pfizer and CDC model are practically the same. Specifically, the risk of RSV hospitalization data used in both models is based on the laboratory-confirmed RSV-associated hospitalization by age from the new vaccine surveillance network. This includes only RSV cases that manifest as LRTI. Therefore, unlike the uncertainty in RSV hospitalization that was a question for discussion for older adults, in infants, it is not what could explain the difference in outcomes. Likewise, the RSV seasonality is based on data from the National Respiratory and Enteric Virus Surveillance System. Both of them are basically in the same ballpark. Next slide, please. However, in this and the next slides, we will examine two main candidates, vaccine efficacy and duration of protection, as explanatory factors for the differences in outcomes. Although both models resort to the same source for vaccine efficacy, namely the Katman's publication in New England Journal of Medicine 2023, which reports the data from the phase 3 clinical trials from Pfizer, each model picks different data points from this source, mainly because none of the Pfizer phase 3 endpoints definitions overlap ideally with the case definition used by the US burden data. Specifically, for hospitalization, CDC uses average vaccine efficacy over months 0 to 6 reported by RSV LRTI hospitalization with an average value of 56.8%. Whereas Pfizer uses the vaccine efficacy for severe RSV medical attended LRTI as a proxy for vaccine efficacy against RSV LRTI hospitalization for full-term infants. For lay preterms, it is 83% of the same proxy value for the full term. This will also help to understand duration of protection. Next slide, please. Although assessing the difference about the initial vaccine effectiveness is important, it is much more the assumption about performance over time. This slide illustrates assumptions about duration of protection by each model. In Pfizer, the linear assumption is based on 4 data endpoints reported from phase 3 until 180 days after vaccination, or what is equivalent to 6 months, then followed by an assumed impact from the 6th to the 9th month, as you can see with in the figure on the left-hand side. That is discriminated by full term versus late term. On the CDC model, the CDC model uses a 6-month efficacy against hospitalization or medically attended RSV-associated RTI. The duration of protection reached 0 at 6 months. The pink shaded areas denoted a higher level of uncertainty of the waning assumption beyond available phase 3 data, as you can see on both sides, on both figures. The CDC model tries to minimize this uncertainty impact on its outcomes, so therefore there is no effectiveness after the 6 months. Next slide, please. Following with differences in inputs, in this slide, we focus on the case fatality rate and on medical costs. Although the base case fatality rate for hospitalization are basically the same in both models, the distinction comes when Pfizer inputs a higher case fatality rate for lay preterms using mortality rates for all preterms. And so in the same bag is included extremely early, and lay preterms as the source, as the denominator for the case fatality rate for all preterms. Also, while the source of the excuse me, where I'm in the slide number 18. Regarding medical costs, the input values used in the Pfizer are either 2 times higher for hospitalization to about 4 times higher for AD and outpatient. Even more, not even the higher value in the ranges used by the CDC reach the average cost value used in Pfizer. Also, while the source of the CDC model is available publicly, it's in the publication that is a meta-analysis of this review of many publications. The source of the Pfizer is reported as data on file and not yet available for examination. Again, for the committee members, they should bear in mind that the higher these input values are, the lower the ICERs would be, or what is equivalent, the more cost-effective the vaccination program will look like. Next slide, please. Cost of vaccination and ICER's incremental cost-effective analysis programs should also include not only the cost of vaccines or vaccine administration, but also the risk of vaccine-associated adverse events and associated costs. Using data reported from phase 3, both models include the rates of injection site reactions and the associated costs, including the cost of outpatient visits. The difference is when dealing with the hypothetical severe adverse events or when considering the incremental risk of prematurity. This potential increased risk of adverse events, considered in the CDC model, when modeled in the base case or as a potential scenario, could influence significantly the ICERs, increasing the cost of the intervention. Next slide, please. To finalize the examination of inputs and then move to the outcomes, this slide explains we will focus on the scores used to represent the quality of life impact of RSV outcomes in both patients and caregivers. When assessing the quality adjusted life days in caregivers, we could see that the point estimates scores used in both models are the same. The difference are in the patient scores, which are a little bit higher for use in the CDC model. But also, the second difference is that the CDC model also relies on ranges from each of these scores, which allows for the analysis and sensitivity analysis of the impact of them. Unlike CDC, the Pfizer model considers only the point estimates for base case without variability, and as a consequence, quality loss is not identified as an influential variable in the Pfizer tornado diagram. Next slide, please. Up to this point, our comparisons focus on the inputs used in the models. The idea now is to see how sizable differences in cost per quality could be explained from outcomes estimated using different input values and assumptions. One way to cross-validate the models is to see if one model could imitate the other by selecting some input values and assumptions. This slide presents the cost per quality for selected scenarios using CDC model. When the CDC model is used, if we focus on scenarios A and B that include Pfizer medical cost and assumptions of duration of protection, we see that the specific impact on the cost per quality. When combining these two scenarios, A and B, in scenario D, as a way to replicate Pfizer estimates, we are able to see that the cost drops to $234,000 per quality, still 3 times higher than the cost per quality reported by Pfizer. Two other important scenarios reported in this slide are scenario E, with potential increase in the risk of prematurity in 1 or 2 percentage points, which could range from about $900,000 if it is only 1 point increase in the risk of prematurity to more than 1.3 million per quality if it is a 2% increase in the risk of prematurity. The other scenario F, deals with the timing of vaccination. And CDC is the only model that presents timing of vaccination. And we can see that vaccinating mothers with births in September to January would provide a cost per quality less than $200,000, as opposed to February, July, which will be in the millions per quality. Next slide, please. This slide, I will pass this slide because this is reporting the same data that we had in the tornado diagram, and I will move to the next one, which is the one that has very important information. Next slide, please. We can return to that previous slide if you prefer. By the same token, Pfizer attempted to replicate the CDC outcomes by sequentially using CDC inputs and assumptions. This slide provides a scenario A, the cost per quality estimate with selected CDC inputs, and the cost per quality value is close to the reported by CDC. It's about 85% approximately, yeah? Please, slide number 2. Next slide, please. I think, yeah, we are in this. I want to focus on this one, yes. As you can see, it's $343,000 per quality, which is very close to the $400,000 per quality reported by CDC. When Pfizer uses in its own model some of the selected CDC inputs. Now, Pfizer returns most of its own inputs and assumptions piece by piece and cumulatively. For example, in slide B, Pfizer returns to its initial vaccine efficacy. And then in the next scenario, it returns to the duration of protection. And then in the subsequent scenario, in scenario D, it returns to the medical costs that Pfizer used. As you can see, it returns to approximately $83,000 per quality, which is basically the same one that was reported by them in the base case scenario. So they are able to replicate some of the analysis. So it seems that the inputs and the assumptions that are being used in the models is crucial. Next slide, please. For the limitations, I will focus on the factors not considered that may result in overestimating the ICER by both models, which means that underestimating the cost effectiveness of maternal vaccination. In the base case, both models assume no protection against upper respiratory tract infection, no benefits of vaccination for vaccinated pregnant mothers, no out-of-pocket costs accrued by caregivers during infant RSV illness. Also, neither model includes RSV-related costs incurred by after discharge from RSV-associated hospitalization or emergency department visits. That's basically what is the productivity tax incurred by caregivers after discharge. Both models assume no indirect effects of vaccination, so unvaccinated people are not protected. There is no protection against RSV transmission. Next slide, please. In conclusion, difference in key inputs among Pfizer and CDC models explain difference in results. Among the key ones are initial vaccine efficacy and assumptions about protection waning, the medical cost data, quality of life associated with RSV LRTI outcomes for patients and caregivers, vaccine-related adverse events. In addition, the CDC model also identifies two important factors that could drive the results and make the difference. Hypothetically severe vaccine-associated adverse events. This is not in the base case, but all in the sensitivity scenario, in the scenario analysis. And the timing of vaccination for RSV season, when it's targeted to a specific periods in the RSV season. Base case in both models, in conclusion, the maternal vaccination will significantly reduce RSV disease burden and disease costs in infants. Data from clinical trials used in both models support the reduction in RSV disease and associated costs. However, economic value of vaccinating pregnant people to protect infants could increase costs. Reasonable vaccine price and duration of protection combined with careful design of seasonal interventions will determine the cost-effectiveness value of routine vaccination of pregnant people during the 32 to 36 weeks of gestational age. Next slide, please. To finish this summary, let me acknowledge my collaborators. Thank you.
Thank you, Dr. Ortega-Sanchez. And with that, we will open both presentations for questions. Dr. Paling.
First, I want to say a very special thank you to both Dr. Hutton and to Dr. Ortega-Sanchez for helping us understand the key drivers of these models. I have two questions. The first for Dr. Hutton is, could you put up the slide again showing the months in which the vaccine is given and the different cost per quality?
Sure, I think that's number 22 or so of mine. Well,
okay.
Yeah, is this the one you're talking about?
I think so. And then I think there was one that showed a range.
I think the next one shows ranges of months.
Okay. Yes.
These slides are comparing RSVpreF vaccination to nothing at all. So this is just RSVpreF, and so we're not looking at nirsevimab at all. We're assuming nirsevimab is off the table. Yeah.
Okay. And so to make sure I'm understanding this table correct, what you're saying is that the cost of giving RSVpreF to pregnant persons in August to January is $186,000 per quali compared to nothing. In September to January, it goes down to $167,000, and for September to December, it's $141,000. Is that a correct interpretation?
Yes.
Okay, thank you. And then if you could go back to slide 20. And I think slide 20 shows the sensitivity of the cost. And one of the things that I think is really important and that your analysis shows is that the cost of the vaccine is a very important determinant on the cost effectiveness. And remembering RSV, as Dr. Long beautifully demonstrated early in her presentation, is a prevalent and costly disease. And so I would like to give Pfizer an opportunity to share, is $295 the cost, or is there going to be any decreasing in cost? Thank you.
We have somebody from Pfizer on.
Yes, Dr. Lee, we have someone.
Hi, Donna Altenpole, Pfizer.
Thank you.
The Abriflo WAC price is $295 a dose for both the maternal and older adult indications. Because the Pfizer RSV vaccine is the same product and the same formulation for both indications, it has one NDC code and one CPT code for reimbursement, requiring one price for both indications. We took this into consideration as Pfizer's pricing strategy is guided by the value that our innovation brings to patients and society, with the goal of achieving the broadest possible access for patients. Based on the results of our cost effectiveness analysis, we priced our vaccine to be both cost effective and reflect the value it'll bring in helping to prevent RSV for older adults and infants. As we shared with the ACIP working group, the RSV maternal vaccine will be a lower cost option and could result in a lower budget impact to the US healthcare system.
Thank you for that statement. Dr. Kimberlin, I will come back to you, I promise. Dr. Lair is next.
Thank you. I'd like to thank Dr. Hutton and Dr. Ortega-Sanchez for their presentations. Could we please go to slide 7 of Dr. Hutton's presentation? And if you look at this one and then the previous slide 6, you'll see the difference between month 6 and 9. And I'm sort of wrestling with my education from a long time ago that the maternal antibodies fade away at around 6 months. And I'm wondering if anyone has a sense of which of these two slides is a more realistic representation of the efficacy. Will there still be antibodies between 6 and 9 months, or will it really drop off dramatically at 6 months? Thank you. We can ask the colleagues too, if anyone from neonatal, possibly Dr. Sanchez might know this as well.
This is David. I mean, I guess in our conversations, we thought that was a conservative assumption. Like you said, there's a lot of data to suggest that the antibodies are gone kind of after 6 months, but we really don't know for sure, and that's why we have a couple of different scenarios here. But there are others much more educated on this topic than me who might have insights into that.
Thank you. Could you please return to my presentation, slide number 16, number 15, please. In this slide, we try to put side by side the two assumptions about vaccine duration of protection. And you can see on the left-hand side, the specific one for Pfizer, whereas on the right-hand side is the CDC. As I said, the pink shaded area is the one that has a lot of uncertainty. There is no data that supports whatever the vaccine efficacy, even residual one, to say that there will be some protection On the right-hand side, the CDC model assumes a more conservative assumption that tries to minimize the uncertainty about whatever vaccine protection will be residual after 6 months. So you can think about which one to believe.
So I thank you. My question's a bigger concept is we have maternal antibodies for other illnesses. Do we have any data about how they wane between 6 and 9 months?
And this
and
is,
then we could go on.
oh yes, this is Dr. Fleming-Dutra. And just to add to that and to your point as well, we do have data from other vaccines, such as Tdap, flu, and influenza vaccines and COVID vaccines, which does indicate that effectiveness post-maternal vaccination of other vaccines has waned by 6 months as well.
Thank you.
Thank you, Dr. Sanchez.
Thank you. And in comment to Dr. Lair, I mean, you know that maternal antibodies can persist in the infant as late as 18 months of age. However, we're talking about what is the protective level of antibody. And certainly, as was mentioned just now by Catherine, with other vaccines, it significantly is reduced after 3 to 6 months. And it makes sense because the levels do go low, and although some can be detected as probably below what it would be considered the efficacious level against whatever disease you're trying to prevent. My comment is related to the vaccine price, and I'm really very disappointed about the expense of this vaccine when a recommendation may be made to provide it to all pregnant women. And I would like to know, what is the cost of this vaccine to countries outside the United States? And is it being priced? Are we being overpriced? And for instance, in Europe, do they know what is the price there? It has been a standardized price throughout the world. Thank you.
Dr. Atwell, did you want to comment? I wasn't sure if you were responding to the last question, but if you wanted to comment on this as well.
Yes. Dr. Atwell was attempting to comment on the previous discussion.
Yes, that's correct, if that's appropriate at this time.
Okay, please go ahead.
Thank you. This is Jessica Atwell from Pfizer. So we wanted to provide a little bit more context into the data that inform the waning assumption or antibody persistence in infants beyond 6 months. So in addition to the data from our phase 3 clinical trial, we also have data from our phase 2b study that measured antibody persistence in infants out to 6 months and compared those levels between infants born to vaccinated individuals and unvaccinated individuals. They were significantly higher among infants born to vaccinated individuals compared to infants born to women who received placebo in the phase 2b. We used the half-life of antibody decay from those data to then extend the potential antibody persistence beyond the 6-month time point. And that modeling, which was shared with the work group, showed persistence even beyond 9 months out to 12 months. Of course, there is no correlative protection for RSV, and so it is difficult to make direct assumptions about what those antibody levels may translate to, but we certainly have data to support persistence in infants beyond 6 months, and that was really critical for informing this assumption about persistence of antibodies and potential benefit.
Thank you. Actually, I'm going to move on to Dr. Talbot.
I need help from,
go ahead.
Sorry, I need help from my pediatric colleagues. Is with the information about the monoclonal antibody and then the vaccine on top with some benefit, but at a very costly rate, is there ever a time that you would or could not give monoclonal antibody to kids where you would be reliant on the mother's immunization?
I can answer.
Dr. Long, I think, go ahead.
Yes, thanks for the question. We're going to discuss this in a little bit about the potential use of both products And I think it'd be best if we probably hold comments till then. There is no contraindication that we know of.
Thank you, Sarah, and I'll try to be patient.
Dr. Kimberlin. Dr. Kimberlin.
Sorry,
Oh, there we go.
I was finding a hard time finding my unmute. I have a couple of questions that are probably more reflective on me than anything else. The base quality, dollars per quality for maternal vaccination, as I'm hearing it here, is about $400,000 per quality at a dose of $295 per dose. In the August 3rd meeting, the nirsevimab cost per quality was $100,000 per quality at a dose of $495 per dose. I don't understand the difference, and I'm hoping that y'all can explain it to me. And then I do have a follow-up as well that maybe Dr. Long, her comment might have changed whether I should ask that. But let me get an answer to this first one first.
Dr. Hutton or Dr. Ortega-Sanchez, did you want to take that?
Yeah, I mean, that's a great question. And there are a lot of different things kind of going on here. I think, a big thing is in our simulation modeling of nirsevimab, the efficacy is slightly better at the beginning. And so slightly higher efficacy. So that's one difference. And then the other difference too, I think, is that nirsevimab can be given to kind of time right at the peak of the RSV season. And that's kind of the idea there is, so if a child is born in, April, May, June, July, for example, they would be given nirsevimab to have that kind of peak efficacy during the season. And so I think those are a couple of things that affect the differences in cost effectiveness of nirsevimab versus the RSV pre, what you're seeing here today on RSVpreF.
And so remind me then of when in your presentation where you did kind of group together the months, so you had different seasons. Are we toward 100,000 per quality for timing maternal vaccination and when it's just a bit before or during RSV season?
Yeah, exactly. So the cost effectiveness of RSVpreF looks much, much better when it's given, kind of right before the peak of the RSV season, because then it will confer the highest levels of efficacy during that peak of seasonality. And so that's a big factor there as well. Yeah.
Comparable to the 100K.
Mm-hmm.
Okay, got it. Second question is, and this Dr. Long may have just sort of said, wait on this one as well. I'm interested in the way I would envision these products would be used is that either the mom gets vaccinated or the baby gets nirsevimab. And I've not seen that kind of a comparison of what the cost of the maternal vaccination would be there. Is that coming?
I can answer that, and Jefferson and Catherine may want to chime in, but because there are no head-to-head comparisons, these really are standalone products that we have assessed and will present for possible recommendation today of the vaccine product. Absolutely not suggested that both be used. Possibility of occasional situation in which a vaccine was given because that would have to be done before delivery, and nirsevimab after delivery, an unusual situation. And I think we'll leave it there until we get further down the line because there will be much better explanations.
I might add, this is Dr. Jones, that the base case scenario of giving the vaccine alone, that is the cost effectiveness when not giving nirsevimab on top of it. So it essentially is being presented if either are given.
Got it. Thank you.
Thank you. Before Ms. McNally, I wanted to just allow Pfizer the chance to respond to Dr. Sanchez, and then we'll have Ms. McNally a couple more comments, and then we'll close this part.
Thank you, Dr. Lee.
Hi, Donna Alpenpole again from Pfizer. We have a tiered pricing strategy outside the US, which allows the price to be contingent upon the affordability of each individual country. As we're beginning to launch the RSV maternal vaccine, the pricing will be decided at that point.
Ms. McNally?
Thank you. I'm wondering if there is a projected uptake rate yet?
So this is David Hutton. In our analysis, I mean, we were assuming 50% uptake. And as I say, anytime you see a nice round number like 50%, I think that's a real hint that really is an assumption. We don't have a whole lot of data about what the uptake will be. There have been some, with that said, there have been some surveys to ask people about uptake. And so we think 50% might be reasonable. But we'll see. And I think actually some of my colleagues might know more details about those studies.
Dr. Long?
This also is a subject that we'll hear much more about with the implementation challenges. The 50%, you can all decide for yourselves what you think the uptake will be. I think 50% is very optimistic for this vaccine this year.
Thank you. And I just have, I personally have a couple of questions I was going to ask. So I noticed, Dr. Hutton, that we looked at, I just want to confirm that what I was understanding, which is you were looking at the incremental price of nirsevimab on top of the RSV vaccine, and not necessarily the combined use of nirsevimab and an RSV vaccine compared to not receiving either. Is that correct?
Correct. Yeah. So if we want to look at something versus nothing, I think that looking at the nirsevimab alone analysis versus nothing, or the RSVpreF analysis versus nothing, I think that's appropriate. And then if you're looking, and then so the next question though is if you've already, if the child has already got some protection from RSVpreF, for example, do you also want to add nirsevimab? And so we don't have something that's looking at both versus nothing.
Okay, but the assumption would be that the ratio would actually be much higher, I think, but I'm not sure. Is that a reasonable intuitive assumption, Dr. Hutton?
If you're looking at both versus nothing, it would look better than both versus something. Because when you're looking at both versus something else, that something else already has some level of protection, and so your incremental additional benefit when you layer on nirsevimab on top of RSVpreF or the reverse, that incremental benefit is much smaller. But I think that is really the right question. I think the incremental analysis really is the right one to be asking, because I think if you're a treating physician and the child already has the mother got the RSVpreF vaccine 3 weeks before delivery, then your question is really what is the additional value of adding nirsevimab on top of that? And I think also it's reasonable to look the other way too and say, look, I know we're doing a really great job of giving kids nirsevimab, and then it's a good, if you expect nirsevimab to be given, I think it's reasonable to ask, what's the value of adding RSVpreF on top of that situation where the child's going to receive nirsevimab.
Okay, thank you. I think I may be asking the question again, but I want to wait until our later sessions for that discussion. Dr. Long, did you have a comment or a question?
I just wanted to say it's very perceptive of you to ask these questions, and please everybody remember, as we later will try to thread the needle of what circumstance would allow a physician to give nirsevimab after a mother has been appropriately immunized, and they should be very, very few. And we'll talk a lot more about that.
Okay, thank you. And then just one last comment, more than for our cost effectiveness colleagues. It's really interesting because I very much appreciate the the looks that you did, Dr. Hutton, sort of by month of administration, because intuitively we understand that RSV has seasonality and the timing of vaccination is fairly tight during pregnancy. So it really depends on when your due date is, how impactful that vaccine will be, and also that you consider that some infants might not get the full protection depending on the timing of delivery. And it occurs to me that in an ideal world, this precision public health approach would actually be the best case scenario. However, recognizing that we often have, access issues and also just the complexity of implementation of such tight timing. I wonder in the future, and this may not be possible, but just, something for us to reflect on as a committee, is that the complexity of implementation in and of itself adds to that cost and that burden to the teams who are trying to deliver that vaccine in a very precise way. It's something we don't necessarily consider. We consider it more implicitly when we talk about implementation in our evidence to recommendations framework. But I did want to recognize that there is an explicit cost to the teams who are trying to deliver so precisely, even if that precision might lead to a better investment in health overall. So it's a trade-off that I think is complex and one that will continue to plague us as a committee. Dr. Paling.
Hi, yes, thank you. I am still struggling with the cost of the vaccine. And so I need some help. And Pfizer, I completely understand that these studies were expensive and that you need to recoup these costs. At the same time, $295 is a hard number for me to swallow. And I am wondering what the cost is in Europe. You shared there's a tiered pricing. And so we do know the higher the price of the vaccine, the more disparities we get. And so it would be very helpful for us to understand how the price of this drug is compared to Europe, for example. Thank you.
Would anyone from Pfizer like to comment?
Hi, Donna Altenpole. As I mentioned earlier, we are still launching the RSV maternal vaccine and have not finalized a price, depending on whether we have separate pricing for our older adult indication and our maternal vaccination. And I will reinforce that how we approach our pricing strategy is tiered pricing based on the affordability of each and every country, with the goal of making sure there's affordable access for all eligible patients. So we have not confirmed all of our IDM pricing at this point, and it would be inappropriate to try to communicate or speculate on that.
Thank you. And with that, we are going to take a 6-minute break. So we'll return at 10 minutes after the hour. I want to thank our presenters from this last session. It was incredibly helpful to have those models presented. All right, we'll see you at 10 minutes after the hour.